We're going to talk about PE standard of care, but I'm going to take a little different twist. I'm going to talk about what devices are available, what therapies are available, and then I'm going to move on to giving you a little bit of data in between, and hopefully by the end you'll see that it's really hard to define what the standard of care is for PE interventions at this point. My disclosures. So I think we all know PE affects almost 1 million people each year. And depending on whether you're looking at submassive or massive PE, you can see the mortality rate at 30 days is pretty significant. And this is the reason why everybody's trying to figure out, what do we do with this? And despite treatment, we still have a lot of unanswered questions. You know, what about post-PE syndrome, CTEPH? How do we affect that or reduce the chance of that happening? How do we treat it once it does occur? And we all know that RV dysfunction does result in increased mortality. And this is really shown by the iCopper study back in '99. So this is not something that we're trying to figure out. We know that when you have PE and you have these long-term effects, mortality in effect is a problem. So obviously there's 3 main categories of PE when you think of it. Most patients show up really with low-risk PE to most hospital centers, EDs, etc. Obviously there's submassive PE, which is the one we're always trying to figure out what to do with. Do we do anticoagulation, catheter-directed thrombolysis, use some of these bigger fancy devices? And obviously high risk or massive PE is something that has a high mortality rate, and that's usually intervened on or treated, quite quickly. So this is really what we're going to focus on. If you look at PE treatment over the years, you can see, look at the first surgical PE embolectomy was back in 1924. We haven't really progressed that much if you think about it. I mean, look at this. We started off with heparin, TPA, CDT, another CDT variation with an ECOS catheter, and then obviously mechanical thromboembolectomy is the biggest thing on the market over the past 5 years or so. But have we really made a difference when we're talking about hemodynamic decompensation, long-term disability, and mortality? And that's really what the primary reason for doing any intervention or treating these patients comes down to. We've obviously got CDT using ECOS. So ECOS was the big one that kind of hit the market and said, we can do it better, we can do it faster. The idea here is you have a thrombolytic catheter in each of the pulmonary arteries. It's a 5 French catheter. Through it, you have an ultrasound fiber. So now you're not only infusing TPA, but you're using ultrasound energy to help break up those fibrin strands, that fibrin network, and hopefully you can dissolve the thrombus quicker, use a lower dose of TPA, and get a rapid result in that fashion. And there's a lot of prospective trials that they did, from Perfect to Ultima to Seattle and so forth, that showed that this definitely works, and there's various protocols. 1 hour, 3 hours, 6 hour, 8 hour, 12 hour, 24 hour, and so forth. But you can see, which one do I use and what's really the standard of care here? There's a nice meta-analysis came out in 2017, which really showed that there was really a low bleeding risk with catheter-directed thrombolysis, and it showed that it was actually quite effective. So we know it works. The question is, when do you do it, and is it better than other therapies that we have for PE? Then what hit the market? About 5+ years ago, all the large bore embolectomy devices and catheters and systems hit. And think about, this is like doing you're basically removing PE without the sternotomy, right? You get rapid on the table cardiovascular improvement. The risk for intracranial hemorrhage is really 0. There are some bleeding risk from injury to the heart, the chorda tendineae, the valves, etc. And so, training and expertise is required. And if you had to do catheter-directed thrombolysis, you definitely had that option. But the question then becomes is this better than anticoagulation? Is it better than thrombolysis? And does every patient really need to have this? And which device do you use? Which device is the one to go to? The Inari FlowTriever system, I think, is the one that gained a lot of popularity in the market over the past few years. It has the Triever suction embolectomy catheter, which is 16, 20, and 24 French. And then if you're unable to get out the clot because it's more organized, it's subacute, chronic, and so forth, you have what's called FlowTriever catheters and FlowTriever discs. These are the newer generation, and I'll show you what these look like. And you can see that the suction embolectomy catheter works just like what you're used to. You have a little bit fancier syringe where you can lock it, You basically put the catheter up to where the clot is, or the PE, or DVT if you're using it for that, because they have a different system for that. And you're basically aspirating or sucking out this clot. And then if you look at this here, sorry about that, I'm going to let this play again, guys. And then obviously if you have more organized thrombus or a little bit more chronic appearing clot, or maybe you have tumor emboli, this may not work. So then you have the other option to use what's called the FlowTriever discs and FlowTriever catheter, and I'll show you what that looks like here as soon as this is done. And so now here you can see that these are where you can use some of the more advanced devices, where you're basically, this is think a la stroke therapy, right? Some of the similar devices that we have to treat acute stroke, you now have available not only in the DVT space, but you have it in the PE space as well. And now this lets you pull out more organized clot and thrombus and so forth. So here's a case. Let's look at what these are all submassive PE cases. And so now you have to think to yourself, well, what is the standard of care for this? Do I do anticoagulation? This patient might not be doing too bad. A little bit of oxygen. They're on anticoagulation right now. They're just sitting in the bed talking. Do we intervene on this patient? And what I'm trying to show you is that really there's PE. There's bad flow to the right upper lobe, the right middle lobe, the lingula, and the left lower lobe. And the question now becomes is what is the standard of care when you look at this patient? And then once you decide that you need to do something, then the question becomes is what is that something? So in this case, we have a PERT team made up of surgeons, cardiologists, radiologists, critical care, pulmonary docs, etc. We all have a discussion to decide, does this patient require some type of intervention? You can see here we decided to use, in this case, the FlowTriever or the Inari device. Again, does it really make a difference in overall outcomes compared to another device? We don't know that. We don't have an answer to that. But we were able to get, pretty rapid resolution of their symptoms. You can see here the before and after. On the left screen, you can see that there's really bad flow. We've improved the perfusion. Then the question becomes is when do you stop? Is it the pretty picture? Is it the symptoms? How do you tell? And so forth. So these are all questions that are really unanswered at this point. In this case, you can see we did the same thing for the left side, and then we were able to improve perfusion, but it's not as pretty. But the patient was better, right? Hemodynamically, they were significantly improved and better. So as a result, we stopped. Their PA pressures were improved. So again, we're not looking for angiographic success or pretty pictures, but rather hemodynamic improvement and symptom relief. The next device that's available is one by Penumbra. This one has a device that has some software with artificial intelligence so that when you have flowing blood, the catheter stays off or the suction is off. And this really gives you really high-powered aspiration. So instead of manual aspiration, now we're using a pump, basically. And this is what it looks like. If you look here, you can see that the green light goes off and on. And basically what it's doing is that when it's in flowing blood, it turns off because we don't want to just, exsanguinate the patient, right? So it turns off. And when it's in non-flowing blood or the catheter is clogged, then the machine turns on to its really maximum capacity. And here's an example of that. Here's another patient, submassive PE. You can see this patient's not doing as well. They're intubated. They've got pretty extensive clot in that right PA, which is really giving very little flow to the right lung. And then you can see on the left side, the descending branch of that pulmonary artery is pretty blocked and occluded as a result of clot. And in this case, we use the Penumbra device. And they have various catheter sizes from all the way up to 16 French. They've got, what they call a separator you can use to kind of macerate or fragment the clot when it gets corked or stuck at the tip of the catheter. And you're able to really get, again, here's a pre and post. You can get pretty good results, especially the more acute the clot is, the easier it is to remove it, as we all know. And then we're able to basically remove the clot from both sides. So here's another case to show you that, and sometimes this device is pretty low profile, so we were able to basically take this patient who has clot in the two places I'm circling there. You can see in the right PA extending into the lingula, into the right upper lobe and right middle lobe branch, and then the descending branch in the lingula is obstructed as well. But in this case, we couldn't go via their groins. We were able to go via their jugular. And you can see a lot of these devices are pretty flexible. They can be used, from various access points in order to remove clot. And you can see, again, we got pretty pictures, but what we were looking for is a reduced PA pressure, We wanted the PA index to be better. We wanted hemodynamic improvement and symptom improvement. So here's a nice article that was done a few years back, which really showed that really when you look at all these devices from Inari to Penumbra to even Rotarex and some of the other ones that are available for PE fragmentation and mechanical thromboembolectomy, in terms of major bleeding, clinical success, technical success, they all are relatively comparable and they do well. Small series came out a few years before that that showed that, again, what about catheter-directed thrombolysis compared to some of the large bore aspiration thrombectomy devices, again, showing that both were comparable. Obviously, you can resolve or get rid of more clot with drug than you can without, but the complication rate using some of these large bore devices was significantly higher, but albeit this was a pretty small study. So what is the standard of care of PE? What do I use? Do I use anticoagulation alone? Maybe patient's not that symptomatic. Do I use a catheter? Do I use a catheter plus ecos? Do I use one of these embolectomy devices? Do I go to surgery? What's the problem? And this is the problem. If you look at the guidelines, look at all these guidelines. They all say the same thing. More data needed, more RCTs. We need an RCT, etc. Evidence supports anticoagulation alone in most cases, and so on and so forth. And this is the reason why most hospital systems have come up with a PERT team in terms of trying to make these decisions, because it's very difficult. So in conclusion, both CDT and mechanical thrombectomy work. We know they're both effective in improving acute RV dysfunction, PA obstruction index, etc. They both have a relatively low bleeding risk in experienced hands. Thrombectomy devices are larger, so we know the risk of arrhythmias and damaging, the valves and the chorda tendineae and so forth is higher. Obviously, training and expertise, like Tim was saying, is the most important thing in these cases. Having a team that you can discuss whether somebody needs intervention or not is important. There's really no consensus on which device is best and which one has the best outcomes at this point, and that's what we need. And like many say, there's tremendous innovation without really true fundamental data. And I'll close with this, is that right now, over the next few years, hopefully this will give us some information. The PE TRACK trial is looking at catheter-directed thrombolysis versus anticoagulation, so it's a true randomized, non-industry sponsored study. It's got NIH funding. It's going to look at whether the effect of CDT on long-term exercise tolerance, etc., is better, and has a lot of good information that hopefully will be coming out for it. Thank you.